Good afternoon, everyone. So, I'll be talking on management of perforated corneal ulcer. So, we all know that it is an ophthalmic emergency and it has to be treated within 24 to 48 hours. So, the first thing that you do when the patient comes to you is you immediately start all the medicines and counsel the patient party and the patient and shield the eye. That's the first thing to do. Why is it an emergency? So what is going to happen once the cornea perforates? So once it perforates, the first thing that you're going to see is there will be chances of hypotony, and there's high risk of microbial entry and chances of endophthalmitis, shallow AC and its problems like formation of peripheral anterior synechiae, disorganized anterior chamber, and long-term glaucoma. So the main principle is to support the globe, form and maintain the anterior chamber, heal the wound, prevent secondary infection, and address the cause. So the perforation can be traumatic or non-traumatic. In that, it could be infected or non-infected. So there are multiple causes for non-infected ulcer. And location, it could be central, mid-peripheral, or peripheral in location. So multiple modalities are being tried. So first one I'll be discussing is the tissue adhesives. So here we use the most commonly that we use is the cyanoacrylate glue. So I'll be discussing the cyanoacrylate and the fibrin glue as well. So cyanoacrylate, it acts based on polymerization mechanism, and the action starts within seconds and the optimal action is at 2 minutes. So the benefits that it is bacteriostatic against gram-positive organisms, and it also disrupts the stromal melting. So it can be done on the slit lamp, or it can be taken under sterile conditions, that is in the OT. So the technique is whenever you see a perforated corneal ulcer, so if there is any slough, you will have to debride it. Once it is debrided, you have to debride 1 to 2 millimeters of the surrounding epithelium, or else the glue is not going to act. And then you have to place the minimum amount of glue. This is the key here you have to follow. And once that is done, you check for any leaks. Form the anterior chamber with air, and if there is leak, you can still use a little more glue. Okay, and once that is done, you can place the bandage contact lens and seal the wound. So there are other methods also being tried. You can also use a small piece of drape. You can put 1 drop of the glue and then you can stick it over the perforation and then place a PCL. That's another method being tried. And the third method, if the perforation is of a little larger size, you can always use a scleral patch augmented with the cyanoacrylate glue. You can use the glue as well as the sutures. Also, a tuck-in scleral patch is also being tried along with the glue. So the main thing that you have to look for is you shouldn't overuse this glue. The moment you put too much of glue, it is going to form a mount, and the surface is going to be very irregular. So there will be a lot of problems. So what are the complications? So if it enters into the anterior chamber, there can be endothelial and lenticular toxicity, and raised IOP, and as I told, cataract formation, and also giant papillary conjunctivitis. So how long the glue should remain? So it can be there for weeks to months depending on the size of the perforation. So ideally we wait for it to spontaneously dislodge till the stromal scarring and vascularization has taken place. So coming to the fibrin glue. Fibrin glue here is biologic, it's biodegradable, less toxic, and it works only for small perforations. So here you should remember that fibrin glue is never used alone. It is used along with other modalities. The reason being it gives poor tectonic stability when used alone. So coming to amniotic membrane transplantation. So the benefit is here, it enhances scar formation, reduced vascularization, it has growth factors, and there's reduced risk of corneal melt. So coming to the technique, so it is done in different techniques. So one of the technique is where you use a filler, that is you use a multi-layered AMG. On that you place another layer of AMG with the basement membrane up, so that is a graft. And then you can also use a third layer of AMG, that is called as the patch. So here the basement membrane is down. So this is a multi-layered technique. And then you can augment it with the fibrin glue as well, and then place a BCL. And another method is called as the augmented AMT, where you use 5 to 7 layers of AMT and then fill that perforation. And then you can use another layer of AMT and then suture and augment it with the fibrin glue. And the main aim is you have to wait for it to scar. Once it incorporates into the cornea, it's going to scar, and then you can place a keratoplasty in future if it's in the visual axis. Some studies have also been tried using the umbilical cord patch as well. Coming to the conjunctival flaps, here you use this method whenever there is a poor visual potential. So the most common thing that is being done is the advancement flap. So this the Gunderson's method is commonly being done. The only thing is there won't be any visual potential because already the vascularization would have taken place and the graft is not going to survive in these cases. Some studies have also been they have also tried making a pedicle flap from the conjunctiva. So it is said that it's much better than the Gunderson's. So that depends from case to case. And next, coming to the Tennant's patch. So you can also use a Tennant's patch. The benefit being it is autologous. There is no immune response, no tissue rejection, and you need not have to rely on a donor tissue or eye bank. And it also gives you a successful keratoplasty in future. So again, you can harvest it from the patient's own cornea. So you just have to take a little bigger size of the Tennant's compared to that of the perforation, and then place it on the perforation, this spread it over, and once that is done, you can suture it, plug it, and you can use an amniotic membrane to seal it, and then you can place a B-seal. It also works very well. Again, that gets incorporated into the corneal stroma, forms a scar, and then you can place perform a keratoplasty in future if it's in the visual axis. Next, if you have access to tissue, then yes, you can use a corneal patch graft. Nothing like it. It restores globe integrity. It could be full thickness or lamellar based on the case. And if it is too small, you can always use skin biopsy punch and perform it carefully. So, and if the infiltrate is too large with the huge perforation, and if you have access to eye bank, you can perform a therapeutic keratoplasty as well. And there are some cases where there will be large scleral melt. So even the keratoplasty, the corneal size won't be enough. So you can do something called as tectonic epikeratoplasty, where the corneal button itself as a whole is being placed, and it kind of provides a good globe integrity. It is not going to give any visual potential to the patient. Also, smile lenticules have been tried to seal the perforation. Again, it depends on the size of the perforation. You can augment it with the glue. And in case of, just 1 minute, just in peripheral perforations, whenever it is there, so you can always design it based on the size and the shape of the perforation and measure it, and then you can do a peritomy there, and you can design the size of the donor graft. It is called as a stencil method, and then you can place a graft. So that depends on the size and shape of the perforation. So to conclude, this thing, it's an ocular emergency and timely management is the key. So you have to avoid perforation whenever you can. But if it is perforated, your main aim is to restore the integrity and prevent infection. Visual rehabilitation is done only in the second sitting. Thank you.
Yeah, thank you, Dr. Aparna. It would have been better if you had used real patient images instead of using animation.
Right.
This is All India conference that you are coming.
Right.
So animation any one of us can see.
Correct.
So one thing is, where you said that fibrin glue, where do you use fibrin glue for perforations? What size and how do you use it?
Very small perforations, less than 1 to 2, like around 1 to 2 mm or smaller than that. We do not use it alone. And if there is a lamellar tear or something, we can use it for those as well.
Not so much. Cyanoacrylate glue is always better.
Yes.
Less than 2 millimeters, more than 2 millimeters, nothing will work.
Yes.
But less than, and if you are using amniotic membrane, as you showed in the diagram, so there where you are using inlay and overlay, there maybe fibrin glue can be used. Otherwise, not much role is there. Dr. Shiv.
Which brand of glue would you recommend to the audience?
We use acrylate actually.
Yes.
No. That is for the cyanoacrylate. I was asking for the fibrin glue.
The one that we use, that Baxter.
Yes.
Yes,
Yeah.
that's the best. But then there is the cost factor. So we have a cheaper alternative. And for these purposes, I think the cheaper one is also good enough. Reliseal is also good enough. One more question. You said that you suture the amniotic membrane and then you augment it with glue.
Yeah. You use the glue first, and if needed, if it doesn't stay, only then you augment, put sutures only if needed, not in all cases.
That was what I was trying to say, that you put the glue first, and most of the cases when you put glue, I don't think it requires suture.
Yeah, but if, as she said, that if it is not stable, we can.
Then you can.
Yeah, you can use 3 or 4.
Yes. Not that you put suture and then
not
you.
Not in all cases.
Yeah.
No. When you are putting suture, Not in all cases you need to augment them with glue. It is when you are using glue, you really don't need sutures in majority of the cases. But if you are in doubt, then only you should put the suture.
Right.
Otherwise, glue alone works very good with amniotic
What
membrane.
she's trying to say is you can create an epithelial defect on the normal cornea. You can put fibrin glue and the final part of the amniotic will stick with the fibrin glue. Over that, you can use a bandage contact lens. Their sutures may not be needed. If you are using anyway the sutures, then you don't need to use such an expensive fibrin glue. It's
You
very,
are
very
adding the cost, no?
Yeah.
Ma'am already
yeah,
said.
the same thing. So the cost factor in a normal person to pay 10,000, 11,000 worth fibrin glue, you have to even think of that. Okay. Thank you so much.
Nice animations.